Right, so well, good to see you all, and I recognise some faces, and perhaps some of you have been through the clinics, and some of you are waiting to come. My background in getting involved in smell and taste disorders specifically was way back as a trainee ENT surgeon, and I'd already sort of decided that the N of the ENT was a bit I was leaning towards. But I just happened to be handed a research project that was to design a piece of equipment to test the sense of smell. And the more I got into doing this research project, the more I realised that there was so little interest in this problem. And then I went to spend some time on a course in Dresden at the Professor Helmholtz Smell and Taste Clinic. And that was like this sort of eureka moment for me. I walked into his facility. He's got a whole floor of the building dedicated to smell and taste, and I thought, wow, this is a revelation. And then when I was on that course, he said, you must come back and spend some time here. And so I held him to that, and I went back. Then I spent a good part of a month sort of spending some time with him, seeing what he did, learning more of his craft. And really then it was a focus for me, once I'd finished my training, to actually have a clinic in this country which could in some way at least give a focal point that he has in Germany. And there are many other European countries, and certainly in the States there are multiple smell and taste clinics, to allow patients who have loss of smell and taste to come forwards. So I set up the clinic about October 2010, and obviously last year we had a little bit of publicity about some of the work, and since then things have been a mushroom, so we've been a little bit swamped, and of course hospital managers being hospital managers like to manage the figures, and they don't like the fact that suddenly a lot of work was going through the door, so we had a lot of difficulty with that, but hopefully now we're finding the balance. Anyway, so what I'll talk to you about today is, it's just to probably re-emphasise some of the points that have been said already, why sense of smell is important. Obviously, Simon's already talked about how he smells, so just a little recap to sort of highlight some points, and a little bit about taste. And then really to get into the causes of smell loss, talk about quantitative and qualitative smell loss, that's the difference between a physical loss of the volume of smell versus these distortions which some people have alluded to. How those should be investigated, and some of the treatment options that are available. Some of the things that are available in the future I will then talk about this afternoon in terms of the research we need to do. So, let me just take this clip. On television to be reminded about other aspects of smell other than just about food. The whole industry sort of gear their advertising towards this. And so it's important to be able to think about the flip side of that and how we deal with when it's not there. This is an excerpt from a book called Aroma, and actually the excerpt's taken from a book by Oliver Sacks. And I think it's quite a sort of fitting statement, which I'm sure one of you would sort of feel strikes a chord. So there are obviously lots of reasons why the sense of smell is important in daily life. Many occupations are dependent on it, so clearly if you're a chef it's a big problem. If you're a fireman you can't smell hazards. A number of people come in and say the first sign that they're aware that there was a problem with sense of smell when all their colleagues had cleared the room and there's sort of ammonia that's being leaked. Suddenly became apparent because their eyes were watering and they were streaming. Obviously, there are simple safety reasons in the domestic environment. A number of people have told me about how they need to blow themselves up because the gas has been left on, or perhaps give themselves food poisoning because they haven't been aware that the food's gone off. And it's just a general sense of well-being. I mean, that little comment in the corner, it's sort of being able to kind of be aware of your own sort of sense of your own smell and your own personal hygiene. Now, Simon's obviously been through with wonderful graphics about this, and this is the only point I want to make here is to bring on to about, so when I talk about the cause of the smell loss, is there are essentially two phases. There's molecules need to get to the receptors, and then there's obviously the transmission of the signal. We can sort of divide up cause of the smell loss into those two halves. And this also really emphasises what Simon was talking about, is the difference between sniffing in through the nose, that's called orthonasal olfaction, and how we experience the flavour of food, which is retronasal olfaction. And you can see there by the map on the right-hand side of the brain, how much of the brain is active when you're eating. Because all these different things are acting together to light up your brain. And that's why the experience of eating is so enjoyable to those to people who can smell and taste normally. And that's really just emphasising that point, is that all these things, there's a lot of medical sort of terminology there, but all these aspects about the process of eating food, is to look at it on the plate, it's the feel of it in your mouth, it's the temperature, it's the anticipation that your stomach has about receiving that food. All of these things add together, as well as the smell and taste, to give you this all-round enjoyable experience of eating. Simon's already learned this pathology and really, taste receptors are evenly distributed on the tongue, and that's simply because of the structure called the taste bud contains receptors for all the different types of taste. Now, people think about taste buds being the little spots you can see on the tongue. Those are not actually the buds, those are the papillae. And within the papillae, on the sides of the papillae, these little pits, are the actual taste buds themselves. Right, so to talk about causes of smell. So I mentioned that we can talk about passage of odor molecules into the nose, and we can talk about passage of the signal then into the brain. So we therefore divide smell loss into what we call conductive and sensory neural. So key conductive causes are problems affecting the nose and the sinuses. And most commonly would be chronic sinusitis, which I'll talk about more. There can also be physical reasons the nose becomes blocked, such as a bent nasal septum or a foreign body block in the nose. In terms of the sensory neural causes, the common cold, there's touched on this a little already. A virus can cause damage to the lining at the top of the nose, the smell receptors, a bang to the head, or due to medication operation. So there are things that we can do as doctors that can cause adverse effects with the sense of smell. And there are a whole number of other small group causes, and obviously these are the things that in a special smell and taste clinic we have to be thinking about as possibilities. Now we find these sort of much less commonly, but these are all potential medical reasons why the sense of smell can be lost. But at the bottom there is no known cause. And 1 in 5 of the patients that I will see in the clinic after extensive investigation, we won't necessarily find anything specifically wrong on the tests that we do. And so obviously those 20% do remain a relative mystery. That said, it may be that a percentage of those are at the first stages of neurological disease, and I'll come back to that later on. So how common are problems with the sense of smell? Well, chronic sinusitis has been shown in some European studies to affect at least 10% of the population. Now that's 1 in 10 people. Now, one of the diagnostic criteria for chronic sinusitis is a reduced sense of smell. We're actually doing a big study here at the University of East Anglia, which is just about to close, for which we recruited 1,200 people. And about 2/3 of the people in the study have reported that loss of sense of smell is a very significant symptom. So you can see already that a lot of people go around with this complaint and don't necessarily make people aware of it, because of the reasons that have already been touched on already. But in terms of olfactory disorders as a whole, studies have been done around the world suggest that it's at least 1%, and in some reports up to 20%, although I think those have been enlarged in older populations, where obviously it becomes more common. So this is a snapshot here of the taste clinic, and you can see here that the diagnostic groups for smell and taste disorders. Now this is a little bit old, and I have to update the figures here. So if we look at the peaks on the graph, these are different forms of chronic sinusitis here. If we add these together, these obviously would populate an large amount of the things that we saw in the early days. These are patients who we've been finding cause for. Other big peaks here are injuries to the head and viral colds. And certainly, with the more recent change in the way that symptoms have come through, and patients have come through, we're seeing there's only an increase in patients who have had a bang to the head and lost a sense of smell. This is just to mention the study that I referred to already, and certainly 2/3 of patients complained. This is a symptom score we call the SUP22, and they ranked it as at least 2 points out of 5, and 1 in 3 patients rated it as one of their top 5 complaints. So it's a big problem for patients with chronic sinusitis. One of the problems we face when people come in and say that they can't smell, or we see people with problems with the nose, is that the awareness of loss of smell and actually how they perform the smell test may be 2 different things. Now, this is a little study I did when I was a trainee. We had a different type of smell test we were using at the time. These patients here are the ones that had a low score, so the smell test ranked them as a poor sense of smell. These are the ones that complained of a poor sense of smell, and you can see here is the overlap. So these people complained of a problem that actually tested okay on the test. These patients here weren't aware they had a problem. So a lot of people out there may not necessarily be aware of a problem. And that's often the case that patients I see will come in and say, well, it's actually because of a family member or a friend pointing things out to them that they become aware of the problem. This is basically a graph showing our smell test scores in the different groups, and you can see here that patients who we don't find cause for seem to be the worst affected. So this kind of the extent of the bar here is right down to the lowest possible range of the score. Patients with a form of rhinitis, sort of hay fever type thing, often badly affected. So chronic rhinosinusitis basically takes up most of my working week. It's one of the most common things I see. As I said already, it's at least 1 in 10 people. It's basically a swelling of the nose and sinuses, but it represents a whole mixed bag of conditions, and which we don't fully understand yet. Some patients have polyps that form inside the nose or swellings. Other patients don't and just have sort of this infective discharge coming out. There are various potential causes for this condition, this group of conditions, and things that we certainly see have a role are allergy, long-standing infection, an allergic type reaction to toxins, that's bad chemicals produced by bacteria inside the nose. One of the worst groups I see is an exaggerated immune response to fungal or mold spores. They're the most difficult ones to treat. Some patients who pick up a lack of specific antibodies, that's the molecules that try and interact with things that are bad, such as bacteria, to try and to fight a defense. And some patients have a sensitivity to aspirin, which is a problem. Now, this is a chronic condition that generally is not curable, but it is extremely treatable. One of the things that frustrates me the most about running my clinic is that people have sort of been dismissed and told, oh, well, it's just spraying waters up the nose. This condition can be controlled, but it has to be sort of tackled carefully, stepwise, and if necessary, with the right medical research of adjuncts, and I'll come on to that. So, other causes of smell loss, post-viral olfactory loss is this situation where a common cold occurs, you get the symptoms of the cold, the other symptoms go away, what you're left with is you can't smell. Now, often what happens in this scenario is that in that situation people find that the cold they had, they appreciate it was more severe than perhaps what was there before. The incidence of it is probably between 11 to 42%, and that's sort of varying through different reports within the literature over the course of the year. But women tend to be more affected than men, and the mean age of this is around between 50 to 60 years of age. Now, one of the questions was asked earlier to Simon about how post-viral smell loss is a problem, how the mechanism of damage occurring. What we believe probably happens is that actually it's repeated colds over a number of years will actually have a creeping effect on causing an impact upon the receptor lining at the top of the nose. And that's why we see this problem become apparent at the age of 40 to 70 years of age. Now, there's still a lot to be understood about the condition, but certainly we don't see younger patients with this problem. So it's what is repeated exposure. As Simon explained to you, the receptors for the sense of smell are extensions of nerves from the brain that are exposed to the environment. And that's quite unusual because all your other nerves are sort of protected by the rest of your body, whereas these nerves are in direct contact with the outer environment. And that's quite a sort of traumatic event for a cell that sort of normally other cells like it would be protected and tucked away. So post-traumatic olfactory loss, again, I hear lots of sort of things that are told to people that come through the clinic about, oh, it must have been the nerve severed. Well, that actually depends really on the mechanism of injury for why you had the injury in the first place. Now, some people may have slipped over, banged the back of their head. Some people may be in a car accident, in which case they've been thrown violently forwards and backwards again. Those can have different impacts upon the contents of the inside of the head. Now, a low impact injury, where there's a back of the head, usually causes the brain to bounce off the front of the skull and can cause bruising inside the brain. That may then cause an injury directly to the areas where the signal's received. However, if you do have a high acceleration-deceleration injury, such as a car accident where you're thrown violently forwards, it does mean that those little nerve fibres that go through those little holes in the skull may, of course, be stretched or torn as a result of that serious forwards and backwards movement of the brain. But there also may be associated injuries to the face at the time. So it may be that at the same time as injury there was actually a blow to the face and the nose had been broken. And so actually you may need to look in the nose and see that the septum's deviated and actually the airflow to the top of the nose is reduced. It may be actually that someone has a pre-existing problem with the nose in the first place, and actually the head injury has exacerbated what was already an unrecognised problem beforehand. So one of the key things that I want to do with post-traumatic olfactory loss is actually to determine, is there a component of the problem which we can deal with? Often the injury to the nerves or the injury inside the brain is very difficult actually going to necessarily reverse. But if you can actually improve any component of that, the passage of smell to the receptors in the first place, then you can optimise the smell loss that's there. One of the things we find when doing the smell test is that those patients who have a reduced rather than absent sense of smell tend to have a better outcome on return. And I'll talk about prognosis on the next slide. So, what we know is from the studies that we've done that if you lose your sense of smell after a common cold or a virus, that the chances of recovery are somewhere between 1/3 and 2/3 of cases within 3 years of the onset of the problem. A lot of people come to me and told if it hasn't come back within 6 months, that's it. And that's not necessarily the case. So certainly there's probably a 3-year window for recovery, and there are certainly things we can do to try and accelerate that, depending on the circumstances. In head injury cases, again, it's probably about 1/3 of cases where some recovery occurs, although work my colleague Thomas Homm has done in Germany suggests that maybe over 10 years, up to 50%, you get some degree of recovery. As I mentioned already, those that have no apparent cause of smell loss, there is a small possibility, and the extent to which we don't quite know, or we want to do studies on, is that this is the precursor to Parkinson's or Alzheimer's. And so those are things that we need to elucidate further. So I mentioned before the difference between quantitative and qualitative disorders, and I'll just talk through a bit of the medical jargon here. So a normal sense of smell we call it normosmia. If it's reduced, it's hyposmia, and if it's completely absent, we tend to call that functional anosmia. We do occasionally have people who have an accentuated sense of smell, which is commonly called superosmia. We may have smell with age loss, and unfortunately, as with all our senses, there is a decline in smell function over time. The glomeruli that Simon talked about in his talk tend to atrophy, particularly after age 65. So there is a certain age-related decline that we can do nothing to halt, unfortunately. And that's presbyosmia. And there is something called olfactory agnosia, where you can actually, there is a kind of verbal component to smell, because as you're all aware, when you grow up, you can become familiar with the smells in your environment around you. And there's a certain sort of verbal component to that, because you attach a name or perhaps a sort of association to that, a memory to that. And if you lose that sort of association, it becomes difficult for you to comprehend the smell. And then on the qualitative side, we can call the dysosmias, are two terms called parosmia and phantosmia. Parosmia generally means a distortion in a smell that's present. So if you're presented with a rose and it smells like rotten flesh, then that's a distortion. Specifically, if it's an unpleasant distortion, because there can be pleasant distortions, if it's an unpleasant distortion, that's called troposmia. But most people experience unpleasant distortions, so actually pleasant distortions are unusual. Phantosmia, however, is a distortion or a sense of the smell that occurs without a signal there. So there's no actual stimulus, there's no smell in the room that would trigger that, but you're aware of the sensation of the smell. And that may be unpleasant, such as cacosmia, or it may be pleasant, such as urosmia. And the important thing here, as Simon mentioned already, is to determine that there isn't a trigger for that within the nose or the head somewhere for that. And that's one of the things we need to do in investigation. So parosmia, as I said already, is this sort of idea that things don't smell how they should. And there are various theories as to why that is, and I'll talk a little bit about that. So this is a diagram again representing, this is the receptors, top of the nose, into the glomeruli that Simon talked about. And you can see here, you've got smell molecules docking with those receptors and firing a signal to the glomeruli. Now, what we believe may happen in a viral injury is that there's a partial knockout of these receptors. And so suddenly this signal is being fed back here, for your Pinot or your Merlot, as Simon nicely showed you, it's distorted because you're getting pieces of that information missing. And then suddenly that signal that you should recognise as something familiar is not. And that's what we believe is the mechanism for this occurring. Then there could be a further activation because the brain can then sort of say, well, this is, I don't like this sort of distorted signal, so it reduces the signal, and therefore the amount that you smell then becomes less as well, so they can actually sort of feed into the problem of smell loss itself. Phantosmia is usually always described as unpleasant sensations, so things like burns or foul or rotten or sewage or chemical things. And it can appear spontaneously. It tends to occur most commonly in patients after head injury or after a viral insult. But it can really be a bad thing in terms of quality of life, particularly with regards to food intake. So, in terms of this qualitative olfactory dysfunction, phantosmia and parosmia, 3/4 of patients studies have experienced hazards, probably 50% experience some degree of depression, and there's this increased appreciation of food, expression of appetite are common because it's just an unpleasant experience. And then we come all the negative things about physical health, financial security, etc., that are on there. I think one of the key things about these distortions is that often they're self-limiting. I'll come on to that a little bit more. So, you can see here on this slide is that certainly parosmia, about 29% of the mean duration is 1 year, and phantosmia the mean duration is 1 year. So phantosmia 53% of the mean duration is 1 year. So often with just a bit passage of time, these things will lessen. And a lot of people that I see further down the line after head injury often say that they did initially have phantosmia, but then it disappeared afterwards. So sometimes often giving a little bit of time in respect to this particular problem is the necessary step to allow for the thing to pass.